not to have you memorize them, but as always, what I want you to be able to do is, on the basis of the prefix and the suffix, identify the joint. Tell me what joint is involved. All of these terms should be fairly familiar to you at this point. If not, as I say, make sure you know or be able to infer what we mean by a manubriosternal joint or a zycosternal joint, and so on. Now, the implication here with the discussion of all these joints is that the thoracic wall is fairly pliable, fairly compliant. It has to be to accommodate the changes that are associated with normal ventilation or breathing. And of course, you're going to have patients with a variety of disorders, everything from costochondritis, in which there's inflammation of the anterior cartilages, in which perhaps as a result of some sort of mechanical trauma. Every breath is painful, or every movement can be painful. Oftentimes there's bruising around the costal margin, especially in obese patients. But to one degree or another, it's important to keep in mind that as these joints become inflamed or less motile, that may impede the ability of the patient to breathe, and also may be an important source of pain. Talk a little bit about the breast tissue. The important thing to understand about the human female breast is that it overlies the muscular wall. So we can see that in the illustration here, for example, the breast tissue simply lies on top of the pectoralis major. Most of it's on top of the pectoralis major. A portion overlies the serratus here, and we'll talk about why that's important with respect to the ability of the breast to move anteriorly on the chest wall. The breast tissue consists primarily of adipose tissue, but also lactiferous tissue. There are usually 20 or 25 glandular masses in there. That the number and the size of the glands are going to change developmentally and cyclically. But in general, that's the typical number. As you look at the issue, as you look at the illustration here, this is not a particularly useful illustration, but it does show us a couple of things I want you to be familiar with. And we've encountered this term before. Previously we called it the clavipectoral fascia when we talked about the anterior wall of the thorax. It's also just called the pectoral fascia. And it's this little membrane that you see here. And we'll look at that again in just a moment. But that, in any case, it's that intervening membrane between the pectoralis and the breast tissue that is termed the pectoral or clavipectoral fascia. Now also, we'll have a better illustration of this in just a moment. You have the fascial membrane there, and then sort of continuous with that is this, what is called stromal connective tissue, or sometimes it's called suspensory ligaments. The suspensory ligaments are also called Cooper's ligaments, so be aware of that alternate terminology. Now, in this figure, we see, for example, the glandular component, that's the colored blue in this case. We see the adipose tissue can be highly variable from individual to individual. But then, intervening between the glandular and adipose tissue, you see these little, I guess that's brown regions in there. Those are the Cooper's ligaments. Those are the suspensory ligaments. And together with the adipose tissue, so together the suspensory ligamentous tissue and the adipose tissue collectively is usually called the stroma. And that's going to be important in your radiology because there has been some epidemiological evidence to suggest that variations or abnormalities in stromal density can be associated with an increased risk of breast cancer. But in any case, just be aware of that term. It's a general term we talked about. You remember where we encountered that term before, stroma? Yeah, so it's a very general anatomical term. In this case, referring to the connective tissue, the adipose tissue, and the suspensory ligaments. Now, also, before we leave this illustration, we indicated that the breast tissue overlies the pectoralis wall there, so you can see the pectoralis muscle back here. But notice there's, again, that intervening membrane. It's kind of hard to see here, right there. That's the pectoral fascia we were talking about. But adjacent to that is this region called the retromammary space or retromammary bursa. That is we've used the term potential space before, but it's actually that retromammary space that allows the breast tissue to sort of move over anterior to the pectoralis wall. And implant procedures. You're in charge of the implant. Where are you going to put the implant? Are you going to put the implant anterior to the pectoral fascia?
I would.
Are you going to put it posterior? Or are you going to put it behind the muscle? Anybody know what's? I do it all three. Oh, yeah, there may be a preference, and I imagine for a variety of reasons in consultation with the physician and the patient, they'll explain the relative benefits and advantages and so on. My point is, though, as you look at the anatomy, I'm aware, at least I've read that all three are possible, perhaps some other variations. But in order to understand those procedures, at the very least, you need to know the basic anatomy. And I'm not quite certain why one, I can speculate, but I'm not quite certain why one procedure would be used over the other. I simply want you to understand the laminar organization of the posterior breast wall there and make sure you appreciate that the relationship between the muscle, the fascial membrane, and the stromal tissue. I don't think there's anything here. We're looking at a mammogram over here. This is normal, so this is the way that the stromal tissue would show up on the left. The mammary glands themselves are just modified sweat glands. These are we've indicated glands that are responsive to both prolactin and oxytocin in different ways. The blood supply to the breast tissue is achieved primarily by these reticulating mammary vessels that you see in this region. And you'll notice they in turn arise from two important arteries that you should be familiar with. The internal thoracic. Now the internal thoracic runs about an inch, probably, well, I guess about an inch or about a thumb's width lateral to the sternum. But notice that, can't tell it from my overriding there, but notice that it's deep to the costal cartilages. And then the other important vessel is the lateral thoracic artery over here that comes off the axillary. And then those two will give rise to the medial and lateral mammary arteries and anastomose in the breast tissue. By the way, this lateral thoracic artery is sometimes called the external mammary artery. Be aware of that. The lateral thoracic is sometimes called the external mammary. So that's a source of confusion when we talk about the mammary arteries. And then the last thing I would have you look at in this particular figure are what are called the perforating branches of the internal thoracic. The perforating branches. Now notice it's kind of hard to see from that illustration because perforating branches are projecting anteriorly. So they're projecting anteriorly, for example, to perfuse portions of the pectoralis major and even a portion of the integumentary tissue in the central thoracic region. See a couple more of these illustrations here. So just be aware of those vessels. We can see there's correspondent venous drainage. The veins have the same names and more or less a very similar anatomy. In general, the vein tends to be medial to at least the internal thoracic vein tends to be medial to the artery, but that's not always the case. The cutaneous innervation of the breast tissue is normally achieved by the intercostal nerves. We'll talk more about these in a moment, but these are the segmental or the regional nerves of the thorax. We don't call them thoracic nerves, we call them intercostal nerves. Remember, these sort of run alongside under each rib, so we'll look at these in more detail in a moment. And then I've given you, as I think I promised on an earlier occasion, about a half a dozen different illustrations of how these cutaneous nerves arise from the ventral or the anterior ramus of the spinal nerve. We'll look at some other figures to see that. But be aware that, of course, the organization of these cutaneous nerves makes any type of surgical procedure in this region rather precarious. You have to be aware where these are. And oftentimes, for example, if you're working on this tissue, you have to sort of make a decision to try to spare as much of this neural tissue as possible. The lymphatic drainage is important with respect to breast tissue because the lymphatic drainage is also the pathway for migration of any type of oncogenic cells. The lymphatic drainage in the anterior thoracic wall is generally mediolateral, and it empties into these axillary lymph nodes we've talked about before, and then depending upon whether we're talking about the left side or the right side, the axillary lymph nodes will drain either into the thoracic duct or the right lymphatic duct, and then those two empty into the venous circulation. There are, as you can see on the next slide, also peristernal lymph nodes, and there is some drainage there, but if you look at the relative abundance of, in any of these illustrations, if you look at the relative abundance of the lymphatic vessels, most of the drainage is lateromedial in this direction, and it's from surface to deep, and generally again toward the axillary region. That portion of the breast tissue you should be familiar with is in what is called the portion of the breast tissue in which lymphatic drainage occurs preponderantly is called, or occurs in the upper outer quadrant of the breast. You can see how the breast tissue is sort of broken down into a quadrant system here. The axillary tail of the breast tissue, which extends toward the axilla, is in the upper outer quadrant. We used this term before as part of your password there, the supernumerary. There are supernumerary breasts and nipples. The nipples, or at least the glandular tissue, is much more common than polymastia. But polyphilia is fairly common, although there are various manifestations of this. Look at the individual here. These additional or supernumerary nipples or breast tissue usually occur on what's called the embryonic mammary ridge. If you've ever looked at any other mammal, a dog or a cat, you may have a squirrel, pet squirrel, or pet possum at home, whatever you have, you'll notice that the mammary glands generally run between the primary nipples here and then sort of toward the pubis or the pubic region. And so that's where they're normally going to be encountered, and they're not uncommon. Indeed, glandular tissue of this type can show up all over the body. If you do a search through the Google, you'll have no trouble finding breast tissue in the leg, in the foot, in the hand. So that sometimes happens. But again, when we talk about supernumerary nipples, most likely occurring on that ridge that you see here on both sides. The lower image is actually of a different phenomenon. This is a male. You can see the male has sort of enlarged breast tissue here. Anybody familiar with that term, with that condition? Gynecomastia, yes. So there are a number of causes for that. It's usually an issue only if it's symptomatic, only if there are problems of one sort or another that may appear, and it can be addressed in a variety of ways. We've already talked about the important large muscles that contribute to the thoracic wall. So I don't think we need to go over these. You by now should be able to identify and locate pectoralis major, minor. The serratus anterior, we've talked about that to some extent. The latissimus dorsi, important in positioning the humerus. In the physiology, we'll talk a little bit about what are called accessory muscles of respiration. The primary muscle of respiration is the diaphragm, and we'll spend most of our time talking about that. But by accessory muscles, we mean muscles that are recruited for respiration in active breathing. When your breathing is altered in order to speak, in order to sing, or when you're involved in some type of active exercise, or perhaps to overcome some sort of respiratory distress. The accessory muscles may be recruited. There are any number of these. There's a lot of debate about the number of these, but certainly any muscle that changes the volume and capacity of the thoracic cage could be considered an accessory muscle of respiration. We're going to look now, we're going to focus most of our attention on these muscles that lie between the ribs. These are called the intercostal muscles. And the intercostals, you can see them here. They have a laminar organization and reside between the adjacent ribs and in sort of a outer to interior direction. We're going to talk about the external, internal, and then the innermost intercostals. By the way, if you look at this illustration, I have trouble, just because I have impaired binocular vision. Anybody else have a problem when you look at the Ackland videos? They seem to become convex and concave. Am I the only one that has that problem? Sometimes an object that looks like a concavity or a fossa. Guess so, never mind. But in any way, there's at the walkway on the main campus. I don't know how many of you have been on the main campus before. As you walk toward the library, the students have painted on the sidewalk over the years, and so there are many layers of paint. And for some reason, my brain, when I'm walking on that, I see the layers of paint, and my brain interprets that as like 2 feet thick, and so I'm walking to make sure I don't fall in there. So yeah, I'll see the psychiatrist and therapist a little later and work on that. But that comes to mind because make sure you understand what we're looking at here. We're looking at the anterior thoracic wall from the back, right? So we're looking from the posterior region here. These are the ribs sort of curving out towards you here laterally. So this is the transverse thoracus here. Sounds like a Greek singer, doesn't it? The transverse thoracus muscle. And you can see it's going to vary dramatically from individual to individual. It won't always be as extensive as you see here. The subcostal muscle, we'll come back to that in just a moment. In fact, the subcostal muscles may also be highly variable. Not all individuals have them, but this would be an example of the arrangement of the subcostals. Muscles of the thoracic wall also include the serratus. Remember we talked about the serratus posterior, superior, and inferior. We indicated these muscles are probably not involved in altering the thoracic volume. So they're probably not respiratory muscles. They probably are too thin to contribute to any sort of active muscular function. The current thinking is that these muscles are probably, although they contribute to the thoracic wall, are probably sensory. That is to say, probably what they're doing is acting to indicate to the autonomic nervous system and for that matter the CNS the degree of expansion or tonus of the thoracic wall. And then the levator is costarum. Those are muscles of the back there. We didn't talk about these too much. These are lateral to the transversospinals, and they extend from the transverse process to adjacent ribs. Their function too is highly debated, and some would argue, the evolutionary biologists would argue they're probably just vestigial, but they do contribute to the posterior thoracic wall. That's our only reason for mentioning them here. As I say, we're going to primarily focus upon these 3 layers of intercostal muscle, which you see there and so on. As we do that, as we begin our discussion of the intercostal muscles, it's important to keep in mind that these muscles, we're going to talk about the external intercostal, the internal intercostal, and then the innermost. When we talk about them as being muscular layers, they are muscular only for a portion of the thoracic wall, and we'll look at what I mean by that in more detail in just a moment. But either anteriorly or posteriorly, the muscle gives rise to simply an aponeurotic membrane, so it's just a flat tendon. And so when we talk about these intercostal muscles, be aware that they're only partially muscular, that these will eventually terminate into aponeurotic tendons. And we have a better illustration of this a little later, but for example, this muscle right here, we're going to call this the external intercostal, and let's follow it around. So it's all muscle there. Let's see what happens right here. If you can see it becomes a membranous. And that's what we're looking at here. That's in that intercostal space, that's the membranous portion of the external intercostal. All right, so Here's the intercostal space here, or sort of the space between the ribs, not technically intercostal at this point. But we can see that between the ribs then we have several layers of muscle. There's going to be the external, the outermost, the internal here. And then at certain points you're also going to have an innermost intercostal. So in general, 3 layers of muscle. Now running sort of interior or between the innermost intercostal and the internal intercostal are the intercostal artery, nerve, and vein. So they're all going to be right in here. And then as we proceed laterally, they're going to tuck themselves up under that costal groove that we saw on the rib earlier. Now let's look at this and note the position of these structures as they proceed mediolaterally. So you'll notice in this region that about the head and the neck region of the adjacent ribs, the intercostal structures, the intercostal vascular structures and nerve are more centrally placed. You want to know that because in any type of trauma or surgical procedure, you want to be darn sure where these things are. And then as we proceed laterally to the angle and the tubercle and so on, they do a couple of things that are important. They move more proximal, they move closer to the rib. But what else happens here? They sprout. They sprout what are called collaterals. So at about the region of the angle there, the intercostal structures, the artery, nerve, and vein, sprout what are called collaterals that then run along the superior margin of the inferior rib in the intercostal space. So here are intercostal artery, nerve, and vein. Here are the collaterals of these. So at this point, the central region is more open and available for any type of surgical procedure. So I just want you to be aware of how these structures run as we move mediolaterally, where and how the collaterals appear, and why that's important in terms of any type of injury or therapeutic procedure that might be invoked. Well, we've already talked about that. So these intercostal nerves all arise from the anterior rami of the spinal nerves. Remember, there's a dorsal and ventral ramus. They are going to give rise, we've already seen several images of this, but we'll look at a couple more in just a moment. These intercostal nerves are going to give rise to the lateral cutaneous nerves, which are the nerves that supply sensory innervation to the thoracic wall. And they also give rise to the muscular branches, which are going to innervate those intercostal muscles we just talked about, for example. Now we're looking here at the lateral cutaneous branches, and all I want you to be aware of is these nerves that you see here arise from the ventral ramus of the intercostals. And the organization is fairly complicated, but I think you can see, we'll look at the ventral and lateral components in more detail in just a moment. You've already seen that before, but we'll go over it again. I just want you to see as you look at this how delicate or how problematic any type of surgical procedure would be in traversing all of this. And then, of course, posteriorly, the dorsal ramus is going to give rise to these structures back here, cutaneous nerves. So you have several of these illustrations. Probably this one's the easiest to follow. So notice this is our ventral ramus here. And then it's going to give rise to this lateral cutaneous branch right there, which in turn issues an anterior branch and a posterior branch. You can see sort of the dividing line right there. All of this is dorsal, Everything in this direction is ventral. So the ventral ramus innervates the thoracic wall, all of that, and provides the cutaneous nerves that innervate the skin and tegument tissues of the superficial region as well. But I think that what I want you to just be aware of is this structure right here, because if you know that, you understand that, for example, this this nerve that runs along the thoracic wall curves or reflects backward to give rise to the anterior cutaneous, which we were looking at here. So these are the anterior cutaneous nerves. But they originate like this. So hopefully, if you were shown an image like this on a quiz or test, you'd be able to differentiate the intercostal nerve from the collateral branches. And you can see the costal root is a little bit exaggerated here, but sort of anteriorly, you can see a rather substantial groove, costal groove, and the intercostal structures ensconced or stuffed up in there pretty cozily. And then you also see the three layers of intercostal muscle. Now, what do you notice about the trajectory or the direction of the external intercostals relative to the internal intercostals?
Opposite.
Yeah, they're almost diametrically opposite with respect to the muscle fibers. The only problem we have here, and part of the problem I have with the explanation of these, and we won't get into it too deeply into the physiology, but these muscles contribute to respiration. These muscles contribute especially to active respiration. And we're going to find, for example, that the orientation of these two layers, especially the external and the internal, is kind of important in determining what happens to the rib cage as we breathe in and breathe out. The problem, again, with the textbook explanation of this is that, in fact, as we proceed from the dorsal side of the thoracic wall to the anterior, this organizational relationship, the relationship of the fibers that you see here, doesn't always hold up. And so I would just encourage you to be a little bit cautious in your reading of explanations of the contribution of the intercostal muscles to respiration, because sometimes it's oversimplified. And I think the most current or the most important or the most recent primary literature suggests that the contribution of these intercostal muscles to respiration is more complex than we previously thought. We're looking at some of these nerves. These again are segmental nerves that are, we could quibble about whether they're thoracic or lumbar. I think we're going to classify them as thoracic, at least they originate in the thoracic region. But their objective, their ultimate function is to innervate the inferior anterior abdominal cavity, or the abdominal wall, and even the inguinal region down here. So we have three of these. We have the subcostal most superiorly. You should know that it arises from T12. And then the iliohypogastric and the ilioinguinal, sort of indicating the region of innervation, arise from the lumbar plexus. Part of the problem here is, remember, the abdominal cavity extends well into the thoracic cage, the rib cage, and deciding whether these neural structures are thoracic or abdominal. There's nothing new here. We've talked about all of this, but I want you to be aware that, I have another picture here, well, kind of this one. These intercostals then emanate or originate directly from the aorta. So the descending aorta is going to arch over to the left side and descend on the left. And it's just like a giant centipede. We'll look at some images of this in isolation later. But it's giving rise to a variety of vessels, including the intercostals that you see here, and that we saw interstitially placed between the ribs. The subclavian artery, as we saw before, gives rise to the internal thoracic, And we'll look at it, what it's talking about here, what it calls superior intercostals. We'll come back to those a little later. And then the axillary artery, as we saw before, gives rise to the lateral thoracic. Remember, the internal thoracic and the lateral thoracic perfuse the breast tissue, for example. There's reference to the superior thoracic artery, as Acklin would say. Here it is. So you can see it's contributing somewhat to the perfusion of the thoracic wall. And so we can see our giant centipede over here giving rise to the BCS vessels and also sprouting a variety of ancillary vessels, most of which we're focused on right now are the intercostals. We can see venous drainage over here, and I have in your slides, we'll come back to this. This is our first exposure to this, I don't think we've talked about this before. You can see the intercostal veins draining into a system that's very different than the aorta. And this is a gross simplification, but what I would have you note is that here's the vena cava here, here's the brachiocephalic, and here's going to be the SVC here and the IVC down here. But in the thoracic region, on the right side, the intercostals drain into what is called the azygos vein. The azygos vein, which is this thing right here. So that's easy enough. But over on the left side, it's not that simple. So in general, most individuals will have two major sort of vertically oriented drainage systems posteriorly. That drainage system will consist of the hemiazygos inferiorly and the accessory hemiazygos superiorly. There's generally, in most individuals, a discontinuity between those two at about somewhere between T7 and T10, T7 and T9. So the problem is that the left side is extremely variable. Sometimes the hemiazygos and the accessory hemiazygos are connected. Sometimes they're not. Sometimes you can see the drainage of each into the azygos here and here at T7 and T8. Sometimes that, as you can see here, it consists of two vessels. Sometimes there's only one. So just be aware that there's an enormous range of variation. Why that is, I have no idea. There's an enormous range of variation in the drainage on the left side. But do be aware of the names of the vessels. We'll come back to that again later. We've talked about the thoracic veins, and we're looking at the internal thoracic vein relative to the, we talked about the internal thoracic artery earlier. You should be familiar with the general surface anatomical structures that you see here that commonly delineate the thoracic wall, at least anterior, the clavicle, the sternum, the components of the sternum, the manubrium, the body, the xiphoid. This is called the costal margin here. We'll come back to that again in just a moment. We've talked about the importance of this because that sternal angle or the sternal angle of Lewis is used anatomically, for example, to locate the second pair of ribs, and can also be used to locate various other structures as well. For example, location of the division of the trachea into the bronchi. The usual surface anatomical lines, and these are purely arbitrary, are the median or mid-sternal line that you see here. That's the mid-sternal or median line. Then you have these two mid-clavicular lines, and you can see how precise the term mid-clavicular is. It's simply about halfway along the clavicle down each side. It may or may not coincide with the nipple of the patient, but that's the other typical reference frame. In the axillary region, you can see there are three lines here, anterior, posterior, and the mid-axillary lines. In general, as far as I know, the only reference there are what we call the axillary folds. There's an anterior axillary fold and a posterior axillary fold. The mid-axillary line is right smack dab between them, and that's usually how that's indicated. And you can see the axillary lines in a more linear representation here, posterior, anterior, and middle. Posteriorly, we have a posterior median line, and then the scapular lines. The scapular line should more or less correspond to the inferior angle of the scapula. Remember, the inferior angle of the scapula is just where that angle is, and so there'd be a line right at that apex of that angle. Again, not very precise. Right along there, and of course, it's going to vary with the individual anatomy and restrictions of the patient. Anteriorly, we've talked about the sternal angle. We've talked about the jugular notch up here, also called the sternal notch. That's going to be important in your CPR type procedures and so on as a reference mark. We mentioned the costal margin. This would be the costal margin on either side. Also an important reference point. And then there's also this, the angle between the two, which is called, sometimes called the subcostal angle, sometimes it's called the infrasternal or sternal angle. And that will vary with the size of the patient in some cases, vary with any sort of malformation we talked about of the sternum. And then there are a few things here to know when we try to use our understanding of vertebral anatomy. I've never been so fond of this reference system, but it is used in virtually all clinical texts. Notice that the apex of the arch of the aorta is somewhere around T3 typically. The apex of the base of the heart, the superiormost portion of the heart, is usually around T5. And then the apex, or the inferiormost region of the heart, is around T9. But note that this is going to change with movement of the diaphragm. The diaphragm's going to move up and down with breathing. So keep in mind this is a labile system, changing with each breath. And this is simply for your amusement, entertainment, and reference. I'm not going to ask that you memorize all of these, but all of these reference points with respect to the vertebral column, but you might find it useful. We will talk about some of these later when we talk, for example, about the cable opening. Any questions about the thoracic wall? If not, and by the way, I meant to say this, but I was late coming in and I forgot to mention this. With respect to your test on Monday in both courses, as I look at the schedule and I look at the time that we have remaining, I think it would be best if we leave everything as it is. I was going to try to maybe abbreviate the anatomy. But here's my objective for the test in both classes. I think it would be best because your final exams, you have them right back-to-back on successive days. That this test in both courses should cover whatever we get through in anatomy today and in physiology tomorrow. So you have Friday off, and then you'll be tested on that material.
You have anatomy as well, right? Is that going to be on as well?
That's right. Yeah, that's what I'm saying. Thank you for. Yeah, exactly. So we'll have both. Actually, let me amend that. So let's see how far we get here. But certainly, it's to your advantage if we do that, because I'm really concerned about the back-to-back exams, because you have other exams at the end of the semester too. But maybe you can remind me, because I'm, as you know, in sort of a senile fog at the end of the class. But let's see how far we get through this. But is that clear? The general objective is that you will be tested on whatever we finish this week on Monday. And then I may make an exception to see if we can. All right, let's talk a little bit about the pleural. That's clear as well, right? a lot of sense. All right, so what we're looking at now are the fascial membrane system that sort of envelops and encapsulates components of the thoracic cavity. Right now we're going to be focusing upon these two lateral compartments called the pleural or pulmonary compartments. All right. So in this illustration, these would be the pulmonary compartments. In the middle we have a sort of mediastinal region. We'll come back to that later. Now, as you look at the illustration here, you can see some dark colored lines. We can see a purple line here. We can see sort of a bluish line here. And that's going to be our focus initially. We want to focus upon these fascial membranes. But before doing that, I want to direct your attention to this green line, and that's the endothoracic or thoracic fascia. And it will always be the outermost or most exterior of these fascial membranes. It's not very robust, and it's easily traversed. It doesn't present any sort of problem, as far as I know, to any type of therapeutic procedure. But it is a thin epineuritic membrane that does lie exterior to this other membrane system that we want to direct our attention to now. And these are the pleural membranes, Now, I guess the best way to approach this is to argue that there is a membrane, a thin fascial membrane that simply encapsulates each lung. Just drapes right over the surface of the lung, and that's called the visceral pleural membrane. The visceral pleural membrane attaches to the wall of the lung. And so that's the sort of pink line that you see there. And now let's follow that around here to what is called the root or the hilum of the lung. So direct your attention to that region. And you'll notice that pink line, whatever color that is, reflects or curves back to form the yellow line. All right? And then as we follow that around, that membrane adheres to the wall of the thorax. That's called the parietal pleural membrane. And it changes color as we proceed, but it comes along here. So again, the purple, purple is the visceral, and then here it's green. It's all green, so you can see it. You can see that the parietal pleural membrane adheres, for the most part, to the wall of the thorax, but does not, well, we're going to be careful here, but is not always apposed or immediately adjacent to the visceral pleural membrane. You can see right here, for example, and this is exaggerated, they deviate. But all of this is parietal, the brown, I guess, what's it called, red, whatever color that is. That's parietal, and then the yellow here is parietal. But please note, and of course we're looking at this illustration in 2 dimensions, but imagine this in 3 dimensions. And you can see there, the visceral and parietal membranes are joined together there at the root of the lung.
The parietal membrane is joined to the thoracic wall, but the endothoracic fascia is.
Yeah, so you're exactly right. So if we just imagine the endothoracic as being part of that thoracic wall, these two are going to be. I just want you to understand that, and this is going to be a little bit complicated as we get into the physiology of this, that the parietal membrane and the pleural membrane are not always in immediate and constant contact. I have to qualify that a bit. But I do want you to pay attention to the deviation here. All right, let's take a break because this gets a little bit deep, so we'll take a break there and come back.